Hello. Thanks so much for joining this webinar today. It's just gone a couple minutes past 5, just giving a bit of extra time for some people to join. But I think it'll be good to make a start now. So the webinar today is for a study looking at patient preferences and experiences of waiting for heart surgery. And my name's Catherine Watson. I am a research associate at King's Improvement Science, and I'll be chairing the event today. So I'm just going to start sharing a couple of slides. So firstly, I wanted to introduce the speakers that we'll have today. So the first is Mario Petro, who's the Director of Cardiovascular Services at King's Improvements at Royal Brompton Hospital, and he's the clinical principal investigator on the study. Manuela Russo, who is the research fellow at King's Improvement Science, and she's the project lead. And then we have Joe Burridge and Rashmi Kumar, who are patient representatives on the project, and Alex Kennedy, who is interim head of public affairs at the British Heart Foundation. So the plan for today is a short introduction by Mario, if he's managed to join us just now. We're hoping for him to join, but I'll check in a moment after going through this to see if he's arrived. And then Manuela is going to talk to us about the key findings on the study. And then Joe and Rashmi will talk a bit about their experience of being involved on the project as patient representatives. Then we'll have a section where we'll take questions to be answered by the panel. And following this, Alex will talk a little bit about a campaign that's being run by the British Heart Foundation. There is a Q&A function for you to submit questions to be considered by the panel, and you can pop in a question there now or any point during the session. And the general chat is also open if you have any just general comments, or if you're having any difficulties kind of hearing us and things like that, and we'll try and help you as much as we can work through that. So I'll just stop sharing now, and we'll start with the introduction. I think Mario hasn't been able to join us just yet. So Manuela, perhaps you can just introduce us to the study and then move on to talk about the findings.
Yes, thank you, Catherine. Very happy to start. Let me share my screen. Okay, hopefully everybody can see the screen. Catherine? Can you see it?
Yeah, that looks great.
Okay, good, thank you. All right, so I'll start. Thank you, Catherine, for the introduction, and thank you everyone for attending this webinar today. As Catherine said, my name is Manuela Russo. I'm a research fellow at King's Improvement Science and lead researcher for this project. Before going into the result of the presentation, I would like to spend just a couple of words about KISS, which is the acronym for King's Improvement Science. KISS is a research program which aims to improve the quality of health and care for people across South London and beyond, The team is composed by researchers from different backgrounds and expertise. We work in close collaboration with colleagues at the Centre of Implementation Science, always at King's College London, with the Health Innovation Network and the NHR Applied Research Collaboration South London. If you would like to know more about King's Improvement Science, please feel free to visit our website at kingsimprovementscience.org. So the study was conducted across 4 major cardiac services from 2 NHS Foundation Trusts, and the services are listed here, and they are Royal Brompton Hospital, Harefield Hospital, St Thomas Hospital, and King's College Hospital. As you might know, waiting list is a big issue for the NHS, and there is a need to reduce the waiting time particularly for heart surgery. Although the strategies that are implemented in the NHS aim to reduce the waiting times, it might happen that these strategies do not take necessarily into account the patient perspective and needs and preferences about how to improve the experience of being on the waiting list. And from the literature, we know that being on the waiting list can have a negative impact on quality of life, meaning not only physical condition, but also psychological well-being. So the purpose of these studies was to explore patient experiences of how the heart condition impacted quality of life and the experience of being the waiting list, and also to explore patient needs and preferences in relation to their upcoming surgery. Also, we investigated what suggestion patients had in order to improve this experience for future patients. The core of the study consisted on an online survey. This was co-developed by researchers, a key team, the clinicians at the collaborating sites, and patient and public involvement representatives. This included not only the 2 members that you are gonna listen after this presentation, and they will talk about their experience, but also external PPI network across the partnership. The survey consisted of 43 questions that were a mix of open-ended questions, so questions where people can elaborate more about their thoughts, so that can put in writing about their experience and thinking, and numerical information. The survey was divided into 4 main parts: general background information in part A, followed by the question on impact of the heart condition on quality of life. And then the other 2 set parts were about the experiences of heart surgery services and patient need for how to improve services in the future. The online survey was open at each site for 8 weeks, and patients on the waiting list at each site received up to 3 text invitations to take part. And as you can see, each site started at a different time point based on the capacity of service managers to send the text out. We reached a total of 929 patients, so meaning that these people were invited to take part. About half of them agreed to participate, which means that they actually opened the link. However, only half of them fully completed the survey, so they basically answered all the questions from the first to the last one. The other half either left the survey without filling in any information or left the survey partially completed. Our sample was eventually made up by mainly men. 70% of them were men. So 75% of the sample was over 16 years old, and the vast majority of the sample was composed by people that defined themselves as belonging to a white ethnic background. And regarding to this point, I would like to anticipate a question that we have been asked by one of the attendees during the registration phase that asked about any potential trends in relation to cultural differences. And I think this is a very, very important point. However, from a statistical point of view, we didn't carry out any specific analysis in relation to ethnic background, because when you have the 80% of the sample belonging to a specific categories, in this case, a white ethnic background, and the other 20% spread across multiple different groups, the interpretability of the statistical result will be a bit weak. So we didn't go into that type of analysis. So when we investigate the impact of the art condition on life domain, we ask question about how often the art condition impacted the specific areas or activities. As you can see from this graph, we are presenting here three domains: in green, family and friends; in red, social activities; in blue, daily activities. We asked people to rate how often they thought that that specific domain was impacted by the art conditions. And the option were never, rarely, some of the time, most of the time, all, or almost all the time. And as you can see here in green, almost 71% of the sample responded that the relationship with family and friends was impacted for at least some of the time or more. Social activities, it seems to be less impacted by the art condition. So 53%, so half of the sample, said that social activities were influenced by the art condition for some of the time or more. And daily activities were impacted for 64% of the sample for at least some of the time or more. When we asked whether people worried about the art conditions, as you can see here, almost the totality of the sample replied positively to this question. So 85% of all the people that responded to the survey said that they worried about their heart condition for at least some of the time. This result was also confirmed by the result on the patient health questionnaire, which is a very short survey that we embedded in our survey. And this included just 4 questions, questions 2 about anxiety and 2 about depression. And the average score was 4.3, which indicates a mild level of distress. So although the mental impact didn't reach any clinically significant level, there were some subclinical symptoms of anxiety that interfered with the daily life and quality of life of people. We also thought that it was interesting to look at whether there were any differences between men and women in the perceived impact of the art condition on life domain. And we found that specifically in relation to social activities, that women reported higher impact compared to men, meaning that their social activities was more negatively impacted by their art condition compared to male patients. Opposite direction is the relationship with the sexual life for men. So when asked about their sexual life, men reported that this was impacted negatively in a more severe way compared to women. The same comparison in relation to psychological symptoms showed that women reported a higher psychological symptoms. We are always referring to anxiety and depression symptoms compared to men. So as you can see from this slide, there is a difference in the way gender, men and women perceived the impact of their heart condition. Here we are showing some information about the experience of using heart surgery services. And we basically ask people to respond either yes or no to specific or unsure about specific statement. For example, we ask about the awareness of the risk associated with surgery, and this is a very good result because more than 80% of the sample responded that they had a good understanding on the risk associated with the operation, meaning that there was a good communication with the surgeon or the clinical team in general. Slightly less, but still a good proportion of patients, around 60%, responded that they had awareness of the length of the waiting list. This result, final result, the bottom bar here, is less positive compared to the other two because it seems that about 60%, this red portion here, 60% of the sample thinks that the waiting list is not entirely clear and fair. This other bar here indicates other aspects of the experience of surgery services. And apart from this bar here, that is that describe the availability of a contact of a key person in case of need, that was a positive result because almost 70% of the sample responded that they had a key person to contact with need. The other statements are less positive. As you can see, only around 30% of the patient responded that they had enough guidance about to look for emotional support in case they need. And similarly, only 40% of them thought that the clinical team acknowledged the stress and the difficulty associated with being on the waiting list. And same proportion, 40%, thought that they had enough information from the clinical team in terms of what to expect while in waiting for the surgery. So communication is definitely something that came up as an important result. And in this figure, we basically see the comparison between the group of people that had a positive experience in blue in terms of communication with the clinical team, with a group of people that had a less positive experience here in red with the clinical team, and the relationship with psychological symptoms. So as you can see, across the different aspects of communication, there is a trend that the people that had a less positive experience with the clinical team, so less clarity about the waiting list, or less information about to look for emotional support, or not a clear contact to reach in case of need, they experience higher psychological symptoms, meaning that the way the communication is dealt with patients has an effect on their psychological well-being, so on level of anxiety and depressive symptoms. When we asked if it was important to be operated by a specific surgeon that they met during the consultation phase instead of another surgeon with the same skills and expertise, but from a team of surgeons that they didn't know. People said that this was very or extremely important. So the surgeon that they would like to be operated from it's preferable to be someone that they have met during the consultation phase. And it's so important for some patients that they are happy to wait longer, even 1 or 2 months longer, as far as they are operated by the surgeon that they know. To confirm this result, we finally asked what was the most important factor for them ahead of the surgery. And you see here that in blue, 54% of the patients responded that having the consultation with the surgeon that they met before is the most important thing for their surgery. This is followed up by 33% that thought that timing is the most important factor. So having the surgery as soon as possible is their priority. And only 8% of the sample thought that the most important factor for them was the location, so being operated in a specific hospital that was more convenient for them compared to another hospital. And in this slide, you see the result of the narrative data. So what do people say about their experience of being on the waiting list? So we analyzed all the text that people included in their survey. And by reading all this information, we found that there are some predominant themes or categories. And these are impact on daily life. So this area basically include all information that refer to the impact that that being waiting for the surgery have on their daily activities, indoor, outdoor activities, also work. And just to give you an example, I'm reporting some quotes. So someone said, I was a keen cyclist. I want to go back to the gym. I cannot do any of these activities. And another one said that I've been advised to my doctor not to do any heavy lifting, which affect my job. So you see there is there are interference in the different aspects of the daily life. Mental health impact emerged as a predominant element. A lot of people, majority of them, are worrying about the surgery, the risk of the surgery. So the people are in some case anxious, also frustrated, and as to give you an example here, this person said that they used to love walking outdoors and meeting people, have developed agoraphobia, which is a specific type of anxiety disorder. And so they are only going out for medical appointment. So there is a real severe interference with from the mental health component associated with being on the waiting list and the daily life of the person. Communication is another fundamental element, and there is a clear need for better communication. These are very extreme examples. So someone that is complaining about lack of communication and is saying that they haven't heard anything since the initial placement on the waiting list. On the opposite, we also have people that are happy and satisfied with the level of communication that they establish with the clinical team and the fact that they met them, which is helping to facilitate the relationship between patient and clinicians. Also, the feeling associated with the waiting is a very interesting aspect, and something that emerged very clearly is this feeling of being on hold. So people have this sensation to be in a limbo, so that they cannot do any plan for the future. They cannot commit to any activity because they don't know when the surgery is going to happen. So they feel that they are stuck in that moment, and this creates a lot of frustration for them. Some of them are the opposite, are very optimistic about the operation, and they see that they will improve their quality of their physical condition and in general their life. About the most important factors, there are like several of them. As I said, establishing a communication and a level of trust and confidence with the surgeon or in general with the clinical team is very important. As you can see from this quote here, this person said that I want the doctor I have been seeing and discussing my surgery with to perform my surgery as I built a relationship with him. So that having the connection with the person is infusing confidence and possibly is reducing the level of anxiety associated with the surgery. Other important factors are, for example, timing. So operation to happen as soon as possible is also another important element. And finally, when we ask for suggestion for future improvement, it seems that keeping updated with the progress on the position in the waiting list is very important, but also having like regular contact with the team. Other people suggest, for example, to have peer support. So being in touch with people that went through the same experience will be like a way to alleviate the burden of being on the waiting list. So in summary, this study is suggesting that being on the waiting list for heart surgery definitely has an impact on different life domains, including mental well-being. Communication is essential. Good communication throughout the stages from the moment that they are inserting the waiting list until the moment of the operation is a very critical moment for them. So having like a clear and stable communication is important for a lot of people. And having more information about where to look for help in case they need. Psychological support is not a service that is provided within cardiac surgery services, but maybe patients are suggesting that being signposted to external support would be a benefit. And in relation to the operation, the most important factors are the confidence and trust on the clinical team and the surgeon, knowing the date for the surgery is very important for them to plan in advance, and also having updates on the waiting list progress. This was my last slide, and I would like to thank all people from and colleagues from the King's Improvement Science team and all the clinical collaborators across the partnership and the program manager at GSPT and all the service managers that really played a crucial role because they sent all the invitations out to the patients on the waiting list. So a big thank you to everyone.
Thanks, Manuela. That's great. So now we're going to hear a bit from Joe and Rashmi about their experiences of being involved on the project as patient representatives. So we'll just give. Did you have something more to say?
Yeah, no, just like
yeah,
putting the slide, and maybe I can stop sharing.
That's great, thank you. So yeah, so just going to say a little bit more about Joe and Rashmi's background. So Joe's interest in research started in 2010 when she was diagnosed with leukemia, and then got involved in research trials and blood cancer support groups. Later in 2018, when Jo was diagnosed with multiple heart and related conditions, she became a member of Heart Voices, which is a community of people using their lived experience to shape the work of the British Heart Foundation. It was from here that Jo first heard about and got involved in bringing her lived experience to improve research. Rashmi brings lived experience from being a carer for his mother, who has multiple health conditions, alongside long-term heart disease, and this has required multiple heart surgeries over the last 4 years. He is also a trustee of a large patients group network in South London. Jo and Rashmi, thank you so much for joining us today to talk about your experiences on the project. So if I come to you first, Jo, could you tell us a little bit about what your role on the project has been?
Thanks, Catherine. It's only now, actually, now we've come to the end of everything, that I've been able to think and reflect upon all the different roles that Rashmi and myself have done over the time from when we started. We were both involved very much at the beginning. As you've mentioned, we both joined with our different lived experiences to join the team, and we were welcomed and made to feel very much part of the research team, and I've always appreciated that. And I've tried to sort of just like think of the different things we've done and the skills we've maybe gained over the time. So first of all, we were involved in the survey design. We were looking at the questionnaire, thinking about the language we were using. There was testing and retesting of things. Thinking about practicalities, how is this going to be, how are people going to access the survey? Is it going to be in person, online? How's that going to happen? Thinking about the community that our intended audience that we wanted the survey to reach, because we really wanted to hear the people's experiences of being on a waiting list. And that was the kind of thing I was bringing into it. So that was a really interesting process. One of us was involved in the ethics committee, going to the ethics panel and taking part in getting ethical approval for the research to be done. Then we were waiting for the results to come in, and then as we began to get in the intermediate time, we were trained up around qualitative analysis, which was new to me, but it was actually really interesting. And we were, again, we were involved very much as part of the team, and our contributions and our feedback was very much taken on board. Towards the end, we were involved in, we were named on the co-authors on this survey protocol, and we also did our own kind of lived experience response to that, as well as doing a visual abstract to sort of present some of the findings in a different way. So yeah, really, there's been quite a lot of different aspects to it. Before I got involved in anything like putting out a questionnaire or a survey, I wouldn't have realized just how much was involved and how much detail and how thorough the researchers need to be around this. So it's been an eye-opener for me, but also I've been encouraged to think that our experiences are able to then be heard by clinicians or researchers and possibly improve patient experience going forward.
Thanks very much, Jo. And so following on from this, Rashmi, from your experiences of working on the project, could you tell us a little bit about why you feel patient and public involvement in research is so important?
Absolutely, and thank you, Jo. You summarize the total involvement of us as members of the public, as members of the PPI group involved of the research, and the level of involvement we did on this program. As Jo said, we were involved from the very beginning, and we worked right across the program and got involved in the analysis of the information that was to ensure that the right message was being picked up by the researchers, because we, the patients and the members of the public, live through those challenges on a daily basis. This was all about waiting for the surgery, and it's important. Researchers are very good at doing the research and collecting the data, but having someone on the program team with lived experience just brings that actual, the elements of reality of what patients are going through. That's psychological, physical, emotional challenges. And therefore, getting involved in the program, Joe found that was the most important to ensure that the right messages was being picked up from the return, because you only get yes, no, I am suffering from these challenges and that challenges, but turning those words into the real lived experience, emotion takes a different kind of measure. And that is why the involvement of patients on any research is absolutely important. And as Joe said, both of us came from the lived experience, because we have both experienced the challenges of waiting for this cardiac surgery, and the impact it was having not just on ourselves as patients, but our wider family and support networks, our friends and neighbors. Because as has been said in the chat that I've been reading, there are wider implications, the emotional challenges, the anxiety that patients and their families go through. And that's what we were allowed to bring into the project, into the research. And we all have links in our communities. We all know of people who are either waiting for surgery, and specifically for cardiac surgery, and what challenges. So getting involved on a project as a PPI member, I found that to be the most important part. And I will encourage any member of the public to actually put yourself forward and share your experiences, because that's the only way, working together in partnership with researchers and ourselves and respecting each other, we will actually be able to deliver that meaningful improvement to health and care services that we are all aspiring to do. Because health clinicians work very, very hard. Why? To make our lives better. And only if we can share with them the challenges that we are going through, they will be able to help us even more. Some of the things that has come out in this research study and the survey was the importance of communication, being able to speak to someone. What shall I do? How shall I manage? How long shall I wait for? That small things can make a lot of difference to preparing the patients to become more resilient, to be stronger and confident of having the surgery, and therefore recovering faster. That's good for the clinicians, it's good for the patient, and it's good for the NHS generally. So that's why I think it's so important for PPI to get in research.
Thanks so much, Rashmi and Andrew. It's so helpful to hear your perspectives and insights, and particularly the range of benefits that can be brought from involvement, not just, as you said, to the project, but can extend far, far beyond this as well. And that's so important. So now we've come to the section in the webinar that's going to be a Q&A session with the panelists. So it's your chance to ask, to be able to put your questions to the panelists. Some questions have already been submitted beforehand, so I'll start off with these, but the Q&A function will still remain open if you have any other additional questions that you would like to submit. We'll do our absolute best to try and address all questions, but if we don't get round to answering your question, then you're absolutely more than welcome to get in touch with us after the webinar, and we'll give details of how to do this at the end. So the first question is, I think that's one for you, Mario, and nice to see that you've been able to join us. It's great to have you here. Someone was asking, How will the findings of the study be put into practice, and do you think some will be more easily implemented than others?
Thank you. Thank you for that question. First of all, apologies for being late at the start of the webinar. I was having technical issues there. I'd like to thank, of course, Manuela and her team at KISS for making this project happen. It started off as a simple back of the envelope idea, and now we have a fantastic project with some really good, compelling data. And I'd also extend my thanks, obviously, to Rashmi and Joe, because as they've already articulated, the PPI aspect of this has been integral, actually, and for sure has strengthened the quality of the project. So to answer the question, absolutely. I mean, the results of this study show us very clearly that the patients, as you would expect, and their families become very anxious and very stressed after they've been placed on a waiting list, because often, as is exemplified here, there's very little communication with regards when they're likely to have their operation, where they sit on the waiting list, when are they likely to come in to have their tests beforehand. And of course, uncertainty results in anxiety. And as Rashmi says, that will influence how they perceive their illness and their coping mechanisms before and after the operation. So to answer the question, we will hopefully use this data to change our processes, really. And I'm very keen for us to make sure that patients are given information about their progress whilst on the waiting list. Now, at the moment in our trust, we have an app that patients are invited to download onto their smartphones, which is really just a clinical app. In other words, it's there for them to report to us any deteriorating symptoms, for example. And it's quite a valuable tool, and that allows us to change the prioritization. So patients who go from being stable to unstable, we clearly do our best to accelerate their treatment and pull them up on the waiting list. I think what would be good is to really extend the app, or maybe have a different app, which focuses on the waiting list. And to have something like, I don't know, a traffic light system, for example, to say, well, you're on red at the moment because you're at the start of the waiting list. And then a month or so later, they say, oh, look, I'm now in the amber stage, which means within 6 weeks, I'm going to be called. And then green means 2 weeks, you're having your operation with an actual date. Something like that, I think, would be really useful to our patients. And then the corollary of that is that they can also ask for additional psychological support, because that did come out very clearly in the study, that often communication is not as good as it should be. And by the way, it's not an uncommon phenomenon that patients, after just one consultation, it's a big ask for them to remember everything. Some patients write notes, some patients record the consultation. We do send a letter. But I think just a one-off clinic episode is clearly not enough. And there has to be further communication and further psychological support during that process. So I think it would be ideal to develop something that provides that communication and support and information about their progress whilst they're on the waiting list.
Thanks, Mario. It's a really informative answer, and also helps address another question that we had come in asking about whether anything can be done to help make the process of prioritizing patients on the waiting list a bit more transparent for families and patients. So that traffic light system sounds like a really interesting way to approach that. So the next question, perhaps one for you, Manuela, and perhaps Mario, you might also have something you want to add to this. So the question is, can the development of chronic anxiety be a factor both in the diagnosis of heart conditions and development of the condition during the lead up to and after surgery?
Yeah, thank you, Catherine. Very interesting question. Yeah, definitely anxiety plays a role in the as a risk factor for developing cardiac condition. It's not directly associated with the causality of the condition. So anxiety by itself cannot lead to a cardiac condition, but definitely the physiology of the anxiety can have for example put an additional strain on the heartbeat and blood pressure. So definitely it's contributing, but yeah, maybe Mario will know definitely knows more about that.
Yeah, I mean, look, as you say, it's very difficult to prove a link, but there's no doubt patients with chronic anxiety or acute anxiety, there is a physiological effect. So circulating catecholamines are increased, their heart rate is faster, blood pressure is higher. And that we know puts a strain on the heart. And in the worst case scenario, patients with aortic aneurysms, a surge in high blood pressure is a really dangerous thing because it can promote the rupture of the aneurysm. So preoperatively, managing chronic anxiety states and acute on chronic anxiety is very important in my view with regards cardiovascular disease. Now, post-operatively, we know that pain thresholds are much lower in patients that are anxious, patients who are depressed as well. So it is important to do our utmost to manage that aspect of their care as well, both pre-operatively and post-operatively.
Thanks, Mario and Manuela. So we've got another question about communication, which I know we've talked on a bit already because the nature of being on a waiting list, it's so important. So perhaps this is another one for you, Mario. So someone was asking, what things do you feel should be communicated to patients beforehand, and specifically, do you think this should include time to explain the procedure before the day of the operation?
Yeah, so most of us, I think it's fair to say, do explain the procedure because part of the consent process, there are 4 components to the consent process. One is to explain what the condition is that they have, their diagnosis, and the natural history of their condition if it were not treated. So in most cases, patients with heart disease, that's the first thing they learn. They've got quite a serious condition that is progressive and it is life-threatening. So the second thing is to discuss the treatment options, which includes medical, surgical, and a combination of the 2 types of treatments. So when they come to see a surgeon, obviously you mention the other things, but you spend most of the time talking about the operation you're proposing to do. And that's what we talk through, the process. And again, by the way, patients do differ. Some patients say, look, I really, please don't give me any details because, I'd rather not know. Others are quite the opposite, and they, ask very, very detailed questions. So we do explain that it'll be involving a general anaesthetic, for example, where the incision is likely to be, how long the operation will take, the basic highlights of what we're going to do during the operation, such as replacing one of the valves or doing a bypass, for example. And then we talk about what they can expect in the first few hours and days after the operation, which includes things like, you know, how early will they be on their feet mobilizing? How will they have tubes and drains and drips connected to them? In which case, when will they be removed? And a rough estimate as to when they're likely to be discharged and go home. And then finally, when they go home, what will it be like? Will they be independent? Will they require physical assistance, etc.? So that's the second domain of consent. The third domain is the complications, the potential complications that can ensue following surgery. Because, you know, open heart surgery, there are risks, there are complications. And again, there's a balance, because you don't want to absolutely flood the patient with all the negatives that can happen, because the danger is you'll frighten them out of having surgery, and very few patients will consent if you really were doom and gloom about the likelihood of things going wrong. But equally, you really cannot gloss over that. You can't just say, sign here on the consent form, everything will be fine. And that clearly is unsatisfactory. So it's a balance. So the third thing is we give them a percentage estimate of mortality. You know, this is a big operation. There's a 1 to 2% chance you may not come through this. And then the other catastrophe is a stroke. If you get a stroke, particularly a severe stroke, of course, that's completely life-changing for you and for your family. And we give a percentage estimate for that. And then finally, the other non-life-threatening complications like infections, kidney failure, arrhythmias, atrial fibrillation, things like that. But again, it's a balance, because we have to give enough information, but at the same time, not frighten the patient. So that's where the doctor-patient relationship is important, because that consultation, one of the aims of that consultation is not just to impart information, but to establish that human link, because the patient needs to feel confidence and has to trust the clinician or the surgeon that's sat in front of them. And the surgeon in turn has to make sure as best you can within that half an hour to 45 minutes that you've established that link, and the vital bits of information that I've mentioned have actually got through. Now, it won't all get through, and as I said earlier, some of it will be forgotten, and that's why we tend to summarize the consultation in the form of a letter that goes to the patient and a copy to their GP. Yeah, I hope that answers the question.
Thanks, Mario. So now we're come to the end of the Q&A session. Thanks to all the members of the panelists for your really helpful answers. And as I said, if we haven't been able to address your question today, you're more than welcome to get in contact with us afterwards. And I'll give details, will be put up on the slide later. So now, Alex, we've got a few minutes to hear from you, and you're going to talk a bit about a campaign that the British Heart Foundation is running. Thank you.
Thank you. So I'm just trying to share my slides. Can everybody see that?
Yeah.
Great, thank you. Yeah, really lovely to be here. The results from the survey and all the discussion today is really resonating really strongly with kind of what we've been hearing at the British Heart Foundation. And it's many of these reasons are why we launched last year our Hearts Need More campaign, where we are calling for more action from the UK government. We think there's much more they can do to, you know, support the NHS into making sure that people get the heart tests and treatment that they need when they need it. So this is our campaign. We are calling for a dedicated heart disease action plan from the government, because we think there's much more, as I say, that the government could be doing to make sure there's enough sort of cardiovascular surgeons and staff, also enough of the the things that we need in our hospitals to sort of get those waiting lists down. And I just wanted to share a few stats with you that, again, really similar to kind of what we've been hearing already. So that first number on the left there, the 427,000, that's the overall cardiac waiting list in England at the end of July. So, this isn't just people waiting for heart surgery, as we've been hearing today. It could be people waiting for echocardiograms, other tests that diagnose a condition. And we know that, from the discussion today, the longer you are waiting, the more anxiety that builds up, your condition could worsen. And 40% of people on that list are waiting more than the recommended 18 weeks. So, these aren't necessarily short waits. So it can be really, really anxiety inducing. And we're also hearing that people aren't necessarily getting the support they need while they are waiting. So that's similar to the results that we've heard today. And we're seeing a huge amount of demand for our services at the British Heart Foundation. So things like our Heart Helpline, which is staffed with cardiac nurses. So just in the first week of September alone, we saw a 27% increase over last year's demand. So, this is a really big problem, and we are really concerned. That middle number, the 100,000, sadly, that's the number of excess deaths we've seen that have been involving cardiovascular disease from sort of March 2020 to the end of 2023. So there's a number of reasons for that, including, the COVID-19 pandemic and infection. But we know that the continued disruption to the NHS and heart services has played a part in that. So yeah, really, really worrying. That number on the right is the number of people that have joined us in calling on the new government to prioritise heart disease and help stop this crisis in its tracks. So in May, we launched a public pledge asking the public to join us because, as you might have noticed, we had a general election and there is now a new government. So we're really hoping to push that number to 50,000 by November, so that we can go to number 10 and knock on the door of the new Prime Minister and say 50,000 people want you, the new government, to prioritise heart disease. So I will pop a link in the chat. So would love if everybody listening today could add their name to that pledge and then share it with your friends and family, so that we can show the strength of support behind this and get the government to take bold action. Thank you. I will stop sharing and pop the link in the chat, but thank you for listening.
Thanks, Alex. Well, this brings us to the end of the webinar, and it's just gone 6 o'clock, and I just wanted to say thank you all so much for joining us. It's been great to share the project with you and have the opportunity to answer some of your questions. Manuela, maybe you can, that's great, share the slide just with, there's just some links there to our website and email addresses if you'd like to get in touch. If we haven't been able to answer your question, or if you have any additional questions you would like to ask us. There's also a link and a QR code to a short feedback form there, and I know the link's been put in the chat as well, so it'd be great to get your feedback on the event, and this will be shared afterwards as well if you don't have time to complete it now. The event's going to be recorded, and so in the next few weeks, after we finalize the recording, we will share this with you. And we'd also be delighted to share the final results of the study with you whenever they're completed early next year. And yeah, so finally, thanks everyone, and thanks as well to all the panelists who've been involved in kind of taking questions, presenting today, everyone who's been involved in the study, and also a few people in the background on our comms team and other members of the team as well who have helped kind of facilitate the smooth running and organization of the webinar today. So really appreciate it. Yeah, so thank you, and we'll end it there.
Thank you.
Thank you, everyone.
Thank you.